From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Everybody, and welcome back to the third webinar in our series for this year. We're thrilled to have author, parent, and nurse Vicki Forman with us today. I'm going to introduce Vicki in a minute, but let me just tell you about a few other exciting events we have at the Bioethics Center. We have 3 more webinars scheduled already for this year. In December, Ray DeVries, a leading medical sociologist from the University of Michigan, is going to be here talking about the value of sociology for moral work or for bioethics work. In January, Ann Hamrick, a leader in nurse ethics, is going to come talk about moral distress. And in February, Lainey Ross from the University of Chicago will be here. And she has yet to determine her title, but anybody who knows Lainey knows that anything she talks about will be fascinating, interesting, and controversial. So put those on your calendars. This webinar series is sponsored by Children's Mercy Hospital and with generous support from the Claire Giannini Trust. So we are, as always, grateful to both of those patrons. For those of you interested in our certificate program, a 9-month online program in pediatric bioethics, all pediatrics all the time, you can get your applications in. We're accepting applications for next year. The program's already filling up, so go to our website or give us a call if you want more information about that. We also have a 1-year full-time fellowship program, so if you'd like, you could apply for that as well and spend the year here in Kansas City at Children's Mercy Hospital with leading specialists in many of the areas that raise ethical controversies in pediatrics. But today we have a special treat. Those of you who are in the bioethics certificate program this year read Vicki Forman's amazing book called This Lovely Life. This is my very well-thumbed copy of This Lovely Life. The New England Journal of Medicine review said this book should be required reading for all staff members who are involved in the delivery and treatment of high-risk infants. And the citation for this book when it won the coveted Pushcart Prize?
Bakeless
Yeah. Prize said, "This Lovely Life is less a book one reads than a book one experiences, and no one who gives him or herself to this writer's terrible, beautiful story will ever be the same again." It's an amazing book, and Vicki is an amazing writer, and we're lucky to have her with us today. Vicki Forman.
Thank you, John. Thank you for having me. John and I have known each other for a while, and it's like seeing an old friend when I see you. So I feel very honored to be here, very happy to be here and share my story and some thoughts that I have on bioethics in the critical care environment, and specifically talking about autonomy and decision-making. So I wanted to just give you a little bit of an overview. My twins were born at 23 weeks gestation. They weighed basically a pound plus, each of them. During the delivery, as many of you know who read the book, I did ask to have the twins, not be resuscitated, but the doctors in that moment said, "What you're asking, we cannot do." My son went on. My daughter had a grade 4 brain bleed, and we took her off life support at 4 days of age. And then my son went on to have a long, complicated NICU course of about 6 months. Came home, was multiply disabled, developmentally delayed, and then shortly before his 8th birthday, passed away from a small bowel obstruction. So if you read the book, you know all of this, but for people who may not have read the whole thing, I hope I didn't give away the ending. During the time that after my son came home, so I was a writer before this happened to me, and I felt while this was all happening that there was certainly a story to be told. And that was the genesis of the book that you've read and that you have in your hands. And between that time of my son being born and my writing the book, I actually made the decision to go to nursing school. So that's by way of explaining the sort of what I'm going to talk to you about today comes from the perspective of a parent, of a writer, and also of someone who's now found herself in clinical practice. So you'll see I have an MFA, an RN, a BSN, and a CCRN, which I put up there just because I think that it kind of encapsulates and helps you understand the perspective that I'm coming from and what it is that I'm, why I say the things that I say. So that's my background. And one of the things that I like to start with sort of a funny story, because I told my mother when I give this is the first time I've given this version of the talk, but this is a conversation I've had often about power, autonomy, and decision-making in the critical care environment. And I told my mom when I went to nursing school that I went to nursing school because I thought when my son was in the hospital that the nurses had all the control. And that I was going to go to nursing school so that I could have the control. And my mom just laughed and said, well, that's rich, So that's where I'm coming from, and it gives you kind of an idea of what it is I'd like to talk to you about today. So I first want to begin with a discussion of autonomy and what I call its illusions. We have our typical definition of autonomy as we know it, a very broad definition. I'm sitting next to a bioethicist, so I have to be,
Very careful.
Very careful. My understanding and my broad definition of autonomy is this idea that we have a sense of the fact that we are somehow self-governing as individuals, that we're not controlled by others, and that we can act somehow in an independent manner in the regular course of our daily life. Okay, so that's sort of my premise that I'm entering into here, sitting next to John. And autonomy. What happens is. Then we have this concept of autonomy with the context of bioethics. And then some of the premises of that is that it rests on this concept that the self is somehow stable and coherent and rational, okay? Which one can certainly dispute in the context of illness and hospitalization, right? So already we're layering the problem of autonomy with some other problems, right? Now we get into the hospital setting where we have what I call sort of the illusion of autonomy, which is we don't, when we walk into the hospital as sick people, we no longer have autonomy as we know it, okay, as we are familiar with it. We have instead what I refer to as sort of a respect for autonomy, and it's represented in this very familiar, this is the old version of the Patient's Bill of Rights. We have a new version, which I couldn't find a good image of, but it's essentially the same thing. You have the right to refuse treatment. You have the right to ask questions. You have a right to know who your healthcare providers are, and other considerations like HIPAA, privacy. These are all conditions under which we try to respect an individual's autonomy. So if we can agree with that, then I can move forward in my argument. So this is basically the premise that I'm working with, is that we have this concept of autonomy. It's problematized in the healthcare setting already, as soon as you walk through the door, even before anything happens, right? Even before a bioethical crisis happens. And John's already frowning, so I look forward to the discussion. I think it'll be a good one. So no better place, I think, to start than this moment in my book where I begged and pleaded with the doctors and nurses. I told them I knew about morbidity and mortality, that these babies could not possibly survive or be normal if they did. Let them go, I said. I know what their lives will be like. I want you to let them go. The OB pulled my husband aside. I'm sorry, apologize about the typo. I noticed this last night. Tell your wife to calm down, he said. These babies will be born with signs of life. The laws of the state of California dictate that they be resuscitated, okay? So I walk in as an autonomous, self-governing individual with a sense of freedom and independence in my decision-making, and this is what happens to me, okay? And then I get a young dark-haired doctor appeared at my bedside and introduced herself as Dr. Tam, the neonatologist. I pled my case to her. I'm thinking a woman might agree with me more, I don't know. Let them go, I said. It's too soon. I want you to let them go. I agree the risks of morbidity and mortality are high. Dr. Tam said, even so, what you are asking, I cannot do. So we have this dilemma, let them go versus what you are asking, I cannot do. And I think what we see here is, the crisis is, and this is not necessarily a crisis that happens in every hospital, but I'm speaking from my own personal experience. The crisis is my wishes and desires as an autonomous, self-governing individual versus those of the healthcare team, but also my wishes and desires versus the autonomy of my babies, who also had a right, certainly, to be protected, right, and who needed a surrogate decision maker for them, right? And then the next point that I think is important here is my understanding of the situation versus their clinical understanding of the situation. So I knew what their lives would be like versus what you're asking we cannot do, okay? So essentially, the reason why I think this is an important moment is because it's pretty much the moment that every person find themselves to some degree, not to the acute degree that I found myself in, but it's pretty much the situation that most people find themselves in when they walk through the doors of the hospital, having lived their lives as someone who could make a decision and make the right decision and know what the right thing was to do and decide and then move forward, versus someone else is now making decisions for you, on your behalf, maybe against your will, for reasons of their own that have value as well, okay? So this leads to this issue, really, for me, it's, well, whose baby is it? If it's my baby, then I should be able to make the decision. I should be able to take care of this child. I should have power and control over the situation. I should be somehow in charge in ways that I am not in charge. Now, that's an illusion because my kid is very sick and I clearly cannot take care of this child, right? But it's disorienting and it's confusing and it's destabilizing, and it really does get to the heart of all the things that as a person we take for granted. Being able to make a decision, being able to take care of a child, being able to follow through on that sort of, and my own values, my own resources, a lot of this has been taken away from me as a parent with a critically ill child. And there are other ways in which this child is not mine because I'm in a culture that I don't know. There are people speaking a language that I don't necessarily understand, no matter how educated I am. There are multiple disciplines, so even when I find one person that I understand and can relate to and learn their language, I have to now meet somebody else who's coming with a different set of standards. So the reason I'm going into such detail about this is because I think you have to remember the effect that this has on parents. So parents feel alienated. They feel disoriented, they feel like outsiders, and they start to feel very helpless as a result. So if you go back to that original Bill of Rights, say, and I have this sick baby that's not mine, that's being taken care of by other people, whose very existence is, in my case, happened against my desires, and I look on the wall at the Bill of Rights, and I think to myself, those rights do not belong to me. Those are not my rights. I mean, in the book I described this moment where my friend Holly and I were like, look at the Bill of Rights. You have the right to refuse treatment. You have the right to bring this baby home. And we sort of laugh and think that's just a joke, So what happens then? Where do we go from here? So this baby who doesn't really belong to me now puts me in a situation where I'm asking, am I allowed? What am I allowed to do? Am I allowed to touch this baby? Am I allowed to bathe this baby? There's a research that shows that parents in the NICU go through these phases, sort of like the phases of a nurse who goes from novice to expert, right? So it's a similar kind of path, which is you go from being very disoriented and out of your element to gradually becoming acculturated to this place where you feel more and more comfortable, and you start asking yourself less and less, am I allowed? But the first step is fitting into the culture. The next step is sort of being good in that culture, right? And then the final step is finding new autonomy in that culture and asserting new autonomy within that culture. And I remember one of the occupational therapists, my son was in our community hospital for a while, and then went to this tertiary care center for eye surgery and came back. And when we came back, the OT said to me, when you left, he wasn't your baby. When you came back, he was your baby. And I think part of that was because I had found new ways to assert autonomy within the context of this environment that was, I had acculturated to. So we go from, so here's me giving Evan a bath. I was told to give him that bath, but I behaved and I gave him that bath. And actually, I see the value in that, because that's also a way of helping parents acculturate to the environment. No longer asking, am I allowed, but show me how to do it. And then there's the family system, which is, are we allowed? Are we allowed to visit? Are we allowed to bond? Are we allowed to create a family unit? Are we allowed, and he was on isolation, so are we allowed to hold him without wearing gowns? No, or gloves with my daughter there. And one of the things I think is important here to remember is that within this system where we feel this sort of loss of autonomy, loss of power, and loss of control, we're still trying to create something that's normal for us, and an environment in which we can begin to assert ourselves as a parent or as a family unit or as a family system. And, I will say that I toured the hospital today, and I think there are so many things going on here that really do support the family in creating, what is sometimes referred to as a new normal, where you do feel like you have agency and you can hold the child and you can bond with the child. And I'll talk a little bit more about ways that I think that's happening here and that really do enhance this experience. But then there's still a bit of a crisis, which is the ways in which we don't bond. It's important to remember we don't really bond until we go home, right? So this was a line that someone said to me when I was in the hospital, someone who was a staff member at the hospital who had been a NICU parent who became a family support specialist who was now on staff. And I thought this was really, really relevant. She said, they say it's your baby, but until you go home, it's never your baby. And the reason I include that here is because when I'm talking about this issue of autonomy and bonding and finding your new normal and reacculturating, you still are kind of up against that original thing, which is, whose baby is it? Okay, and I think the reason why this is important is because no matter how much of welcoming and family-centered care there is a way in which if it doesn't completely feel like your baby because someone else is taking care of this child because it's necessary, I think there's a power and control start to become an underlying issue. So I can't make decisions. I don't really have power over this situation. I don't have a lot of control over the situation because so much is out of my control. And this baby is being mostly taken care of by other people. Then fundamentally, I still don't really feel autonomous, okay? And I'm not saying there's really much you can do, but the reason I'm describing it is because what happens when people don't feel autonomous is, and when they say it's your baby, is I think we start to dig in and we start to find things that we can control and we start to assert power in ways that we can. And it's funny to me in my clinical practice to think that when someone comes in and says the patient's refusing something, and I think to myself, well, that's interesting because you have the right to refuse, and that is your ultimate right. So when we talk about a truly autonomous person in the healthcare setting, in this critical care environment, what is the ultimate right that this person has? The right to say no. And what does that do? Well, that stops everything in its tracks, doesn't it? So if you look at the patient's Bill of Rights, in a way, the only thing it should say is you have the right to say no, And so the reason why this is important, I think, is because we forget that this is probably underlying almost every bioethical crisis that we have. We know it intellectually, but we haven't connected the dots that from the moment someone like me walks into the hospital and no longer has the autonomy that I'm used to having, and this is probably a very obvious statement, but I think we need to remember it, from that moment on, we are adding fuel to the right to say no moment, okay? And we're also creating this place where in that moment of crisis, all of the frustration and all of the feelings of helplessness are feeding into that bioethical crisis. So it may not be a crisis in about that thing itself. It could be the crisis that's been brewing, right? Does that make sense? So to talk about fostering autonomy, I mean, the things I saw today I thought were, this really so beautiful and ideal, and I know that it's something that we all work on in these critical care environments, which is to give people ways to feel like they have a role, to ways to feel like they have power, ways to feel like they're part of the situation. And there were nurses in the unit who felt determined to label things and give us mementos, and at the time I really felt like, this is crazy, like this kid's really sick, I don't want a handprint. That kind of freaked me out in a way, like what am I going to do with that if something happens to him, but now it's something that I'm so glad I have, and I really understand it, and I understand being in the clinical practice why it matters and what it does to normalize the environment and to give people soft rooms and quiet and turn the alarms down. And the best thing is that we're all really working hard to do that. In my experience, there wasn't enough of that, but I know that this is something that we bring to our practice every day, and I think it's really, really important and helpful. So anything that normalizes the environment, obviously bringing respect and dignity into your communication is very important, and I think we all work on it, but there still aren't those moments where we label people difficult and we think about the problem, the troublemakers, and in our minds we try to not use those words, but I think we still kind of do use those words sometimes. It's human nature, certainly. So anything that we can do to maintain that respect and dignity, I think really helps to help people feel autonomous, because they don't feel like they're just being some sort of cog in the system. They actually have they're a person, they have agency, they are a human being who is going to be imperfect, so therefore we don't need to label them. They're actually behaving like a human being. They're not being difficult, they're being human, And then, of course, communication. The ways that you communicate, the ways that we communicate, the sharing of information, but also the meaning of information. And there's, we all work on this very hard, but that helps people feel like they're part of the decision-making process. And, what I like to say about that is that if you're working hard to communicate and you're sharing information and the meaning of information, even when there's what we might call a bad decision, parents feel better about the decision. So even if there's a difficult decisional outcome, most people they're not as likely to dig in as they might be otherwise, right? Mm-hmm. So we're going to have conflict. It's going to happen. The point of this slide is my son's physical therapist was determined to get him to walk. He came home very delayed. I think he sat up at like 2 years of age, and never really learned to crawl. Wasn't interested in crawling. My daughter didn't crawl either. So, she's a typically developing kid, also didn't really crawl. But we got to this point where everyone decided he had to walk. This was the goal. He had to learn how to walk, and I wanted him to walk too. I mean, believe me, I was all for that. I thought he would be happier if he was upright. He would be happy. He was blind, so it certainly would make things easier for him if he knew how to walk. But because he was blind, it was going to be a lot more difficult to teach him how to walk. So almost every physical therapy session for a year looked like this, And so the point of the slide is that he had his agenda, and she had her agenda. And we all had our agenda, and we're definitely going to come in conflict. It's going to happen. There's almost no avoiding it. But to get back to my original point, if we remember that what we thought of as our autonomy and what we think of as having autonomy is problematic in the healthcare setting, then we'll also remember that when people dig in and when we have conflict, this is part of something that's been going on for a while. So we're not going to resolve it immediately. We're not, no matter how much parent and family-centered care we provide, no matter how much we normalize the NICU, no matter how much sharing of information we do, no matter how good our communication is, we may find ourselves in conflict, and the conflict may not be about the thing that we think the conflict is over. The conflict may be about how I came in and wanted to hold my kid, and the nurse who was working that day was so busy and overwhelmed, or however you want to describe it, didn't facilitate that. And now I'm remembering all the other times I didn't get to do what I wanted to do, and all the other times that my kid was too sick to be the kid I wanted him to be. Okay, and on the side of the caregiver or the healthcare provider, that person may be remembering all the other times that he or she wished it had gone differently, and that kid didn't get NEC, and just the frustration that builds on both sides. So when we reach a bioethical crisis, it may be about the thing itself, but factoring in and feeding into that are all the other moments. So what do we hear in these situations? Why aren't they listening to me? Does the family know what they're asking for? Are we allowed to do this? Are they allowed to do this? I mean, it was interesting. John asked me to be part of this roundtable discussion. It was an ethical dilemma about removing support from a kid, and I participated and offered up my insights as a parent and at the time I was a critical care nurse. And then the article came out, and the title was, "Are we allowed to discontinue life support in this child?" And I was really taken aback because I didn't know that was going to be the title. And so, this question of who's allowed, which I referred to earlier, is, I think it's really, it's interesting. Who is allowed? Are we allowed? Am I allowed? And, that brings us back to all of the things that you are familiar with in the bioethical crisis. And what you say is, what can and should we be saying in these situations, and what is the best that we can do in this situation? And so the questions you then ask are the parents being heard, right? Am I being heard? Is the language that I'm using, am I even using the right words? Because if I'm not being heard, then I'm not using the right words, and especially, I think, in moments of futility, this is where we really reach the distress. And I think one of the things to remember in the situations that involve futility is that this is also an iterative decision-making process, right? And I know when I worked in critical care, it was funny because we would say, well, yesterday the patient was a DNR, and today they're not. Why? Why is that? What happened? And we'd get mad. We'd get angry. We'd be angry at ourselves. We'd be angry at the family. I did all that work. I did all that work. Well, the person who decided is the person who, remember, left the autonomy as they know it at the door, tried to find a new kind of autonomy, may have decided to dig in, may not know what they want, and is now involved in their own iterative decision-making process that has to do with their own autonomy and their own decision-making, in this moment of bioethical crisis. And one of the things that I read recently, a quote from Dworkin, which is, true autonomy is being the author of your own life, right? So in these moments of bioethical crisis, when values conflict, what are you really looking at? You're looking at someone who's ultimately trying to find some autonomy for themselves, right? And then I'm going to end with this concept, and I'm really interested to hear what you have to say about this. This is something that I'm working with, is the idea that maybe what we should be saying is, from the beginning, I could get this wrong. Okay, I as a provider could get this wrong. I as a parent could be getting this wrong. If I had, going back to that original statement, I know what their lives will be like, okay? No one said to me, you don't know, because I don't know, you know? And I think that when you look at issues of power and control, underneath it all, there's an idea of wanting to be right, okay? And our clinical practice trains us to be right. We need to be right. We need to know what the right thing is to do, because that's what we're there for, okay? But in bioethical crises, you could get it. I could get it wrong, you know? And I know that it's kind of like putting apples and oranges together, but I'm trying to sort of figure out a way in which, and where I came up with this was, I had seen a Frontline episode with Atul Gawande and his discussion of being mortal, and at the beginning of it, he said, doctors, you know, we're so trained to be right, and what about, can we ever say, I could get this wrong, and what would happen if we started saying that to ourselves and maybe even to our patients? And so I wanted to make this the whole sort of crux of this talk and this idea that I'm working with. And then I read his book. I couldn't find it in the book. I went back and rewatched the episode. I couldn't find it in the episode. And I think this is very funny. This lacuna is interesting to me because I'm sure he said it, but it seems to be gone. So that's another reason why I think it's important to bring this up. And, you know, the stories we tell ourselves when we're giving care are really important to us. And they're our own stories and the stories that we're using to author our lives as a clinician when we walk into the room to take care of someone. Those are important stories. They help us do our job every day. But we have to remember that we may not be right every time. We may not have it right every time. And even if we use evidence-based practice, and even if we do patient and family-centered care, and even if we know all the research about something, there's still a chance we could be wrong about it, you know? And so someone captioned this, will someone tell Alexander to be quiet, I'm trying to sleep? And, you know, so he has his finger in his ear, but I'm sure that's a purposeful gesture. That story that whoever wrote that needed to tell, that was a great story. But, you know, I mean, that's one version of the story, isn't it? Okay. And then the other thing that someone asked me when my book came out, I was giving a reading and someone said, so going back to that original moment where you asked them not to resuscitate your twins, now that you've had your son, raised your son, learned what you've learned, gone to nursing school, and he's passed away, do you still feel that way? Do you still believe that? Is that still true for you? And I thought it was a great question. I thought it was a brave question. I don't think I could have asked myself that question. And I said, I don't know. That's the only answer I have. I want to say no, but I can't say no, you know? But I will say, we could all get this wrong. And I think I got it wrong, you know? So I just want to show you this. It should play, yes? Is there something I need to do? Do we have? Press it. I won't show you all of this, but so these are his first steps after all that. Sorry about the corny music. It's a little sentimental, but. So there's autonomy, right? He decided when he would do it and how he would do it. Anyway, we don't have to watch all of it. I didn't want to edit this video, but so I think, you know, it's important to remember that the things that you know, just going back to the original point, which is we do take this everyday autonomy for granted as individuals, and we have to remember that when we take care of people in the hospital, it's that version is really not what we experience on a daily basis. The restrictions and the limitations and the way the structure works really undermine that experience of autonomy, and it's very disorienting, and it's very frustrating, and it can be very confusing for people, and it does account for what we then label bad behavior, and it does factor in, I think, to the crises that we see. Those aren't isolated. They're not happening just over that one individual moment. They're happening because of everything that's led up to it. And I think we all go to work hoping to do better, and knowing that our hearts are in the right place, but we're also working in an environment that is complicated and difficult for people, you know. So I'm happy to hear your questions and your reactions, and thank you for listening.
Thank you for that lovely talk. It's
Thank you.
amazing for me to hear how your thoughts have developed. I think I read the book shortly after it came out in 2010. I heard you speak probably 2011 or so, and now it's 2016. 16 years after the twins were born.
Yes, 16. Evan would be 16. He'd be driving.
So I'm going to ask you a question about that soon. But first, let me just remind people who are watching online, if you have a question or a comment, type it in that little chat box in the lower right-hand corner of your screen, and we will read them out, and you can have a chance to ask Vicki or discuss what's on your mind. People in the audience here as well, just use your microphones on the table. But when you think about, like, this was 16 years ago, now the book was obviously sort of a first set of reflections, because it was written looking back, but written almost...
And written somewhat at the I kept a diary at the time, so some of that was contemporaneous to the experience,
And it's written as if it's in the present, it's written in the present tense, but from your perspective.
With reflection, yeah.
And then, once the book came out, you had these book readings and people asked you questions, and you started going to conferences. And then you went to nursing school, and now you're working professionally in the operating room, the place where there's probably the least autonomy.
Absolutely.
Anybody.
Zero autonomy. The right to refuse. That's it.
Yeah, you don't have to go in, but once you go in, you're
no
put
autonomy.
to sleep.
Yes, you're put to sleep.
So how has your thinking changed about all these issues of rights and autonomy as you've gone through these different stages of reflection?
I have a lot more compassion for how hard it is to maintain respect and dignity for people, and to promote decision making and power in that environment. And I have a lot more respect for the challenges and what goes into making that happen. And I also have a lot, I would say, my horror when someone doesn't do it well has not abated, and as a patient advocate on a daily basis, I still see people not doing it well, and I still feel just as upset about it. So I continue to identify with a patient more, I think, than I identify with being a clinician. But I do my job as a clinician because I'm there to do that job.
Which sometimes must involve
conflict of my own?
Conflict, compromise, a sense that people are making bad decisions, perhaps, or that they don't quite understand the decision they're making.
I have a lot of compassion and empathy for how difficult the decision is, and what I do is I try to support when I see a decision maybe not going well, or when I see the labeling that I talked about, or when I see this idea that someone's being difficult. I try to remind people that I work with, if they say something like that, well, they're in a hospital, they're sick, they're undergoing surgery. How would you feel if you were in this situation? Or even the simplest thing, if we're taking care of someone and a mundane example, the sheets are dirty and the doctor and the anesthesiologist is in a hurry to get the patient back onto the bed. I'm like, Dr. Kim, I wouldn't put you on dirty sheets. Why should I put this patient on dirty sheets? So I would say I continue to identify with the patient, but I have a lot of sympathy and compassion for and empathy for how difficult the job is, you know, on a daily basis. Does that answer your question?
Yeah, or it moves the discussion forward
Okay.
anyway. The other thing that struck me is in pediatrics in particular, more perhaps than in other areas of medicine, the concept of beneficence, or what's in the child's best interest, almost outweighs parental autonomy. And when in the NICU they said, I'm not allowed to make that decision, or we can't make that. It wasn't that they were acting in ways that they thought necessarily reflected their own values, but it seemed to be a sense that society has decided, or the state of California, whether they understood the state laws accurately or not, but that we all have an obligation to do what's best for the kids.
Absolutely, and I think that adds a whole other layer of complexity, because the child can't say, and the child can't decide, and the child's autonomy is questionable at that point. So we are in a position of having to apply those other principles of beneficence, of justice, and that is the job of the team. That is the job, and I'm relieved that the team felt that and saw that that was necessary, because had they not, I might have been angry about something else, which would have been their lack of consideration of justice in the situation, or beneficence, you know. So I do feel they were doing their job.
Or the video at the end, which is so powerful. And when you show it, you say that's autonomy.
That's autonomy.
That's autonomy that Evan only achieved because people overrode his refusals for a year,
and I think
said, we know what's better for you.
Absolutely. And you know, I have to thank you, John, because I think this is something that it has been a process for me, and it's something that I've learned from talking to you and hearing you speak, and from meeting other people, and from getting those hard questions, and maybe this is why I include this I could get this wrong concept, because you know, one of the things that happens when we assert our autonomy is we have to believe we're right, because otherwise we couldn't do it, and we don't want to think that we're wrong, you know, but they are two different things, you know.
Or at least think we have the right in that authorship of your own.
The authorship, and maybe the right to be wrong, you know, to make a mistake. So you know, it's an interesting dilemma, but I'm grateful that I had my son and that he lived so that I could learn those things. And, you know, that's very powerful.
We are getting some online questions, but I want to use my prerogative as holding the mic here to follow up on this just a little bit and ask a question that I'm interested in. The discussion of autonomy. I'm reminded that you know, no decisions are made in a vacuum, absent any constraints or expectations.
We exist in relation to others.
And so you know, all decisions are always being made in a certain location that's subject to certain laws and certain social norms. And then when we talk about medicine, we're talking about clinical professional guidelines and institutional norms and policies and these sorts of things. And so there are all these layers of that sort of diminish autonomy, and we may not even be aware of it, right, in the sense that, you know, we're living in the United States versus some other country, we're living in the state of California versus some other state, we go to this hospital where they do things this way, and as you pointed out in the book, had you gone to another hospital somewhere, you may have had an entirely different experience. I'm just, what all this is leading to is a question about, have you reflected on how you see that delicate balance of having laws, having policies, perhaps guided by considerations of justice and social utility, but then noticing that every time we do that, we've constrained that realm of autonomy and discretion for individual persons. Sometimes they find that comforting. They find it comforting that they don't have to make a decision and bear the full burden of that. But other times it's extremely, as you say, disorienting and constrictive and alienating in many ways. And I'd also kind of point out that the same effect can be had by the clinicians, which maybe you've experienced as well, that the laws and the policies can kind of give them this sense that they're not allowed or empowered to do certain things. And so one of the things I really noticed, especially in the first chapter of the book, is this sense in which there's an alien force present that's kind of making decisions for everybody, and it's not answerable to any human agents, right? And so it's like you felt like things were fated, you felt like things were coming down from on high.
Yeah.
The way that the clinicians talked about it was as if they couldn't do anything about it.
Yeah.
Things couldn't be any other way, and yet there are human agents behind all of these. These aren't facts of nature, right? That are
in my hospital, a voice comes on at 9:00 and says, "Attention, attention, visiting hours are over."
Yeah.
I don't know who that is, but someone's decided visiting hours are over.
Someone's decided that's exactly right. And so again, just kind of my question is, have you found? I mean, you've had both ends of it now as a parent and also as a clinician. But how do we balance the need for some laws and policies and norms against that desire to preserve a space for meaningful autonomy and discretion?
I think it's an excellent question, and I think it's why I find myself talking about this and feeling like I'm stating the obvious, and also understanding that I'm actually not stating the obvious in a certain way, because the obvious point is that we forget the position in which we put our patients. That's the obvious statement. And so the question is, what do you do with that, with all those layers that you're describing, the institutional policies, the policies on visiting hours, the way you can communicate. As a nurse in the OR, I'm supposed to call the family every 2 hours to update them. I have nothing I can tell them. What am I really doing here? Am I giving them autonomy? I don't think so. Do I have autonomy? Not really. If there's an emergency and things take a turn, am I supposed to make that phone call or not make that phone call? So I think the main thing is for us to remember that condition exists, and that we are operating within this realm of what did you call it? Diminished autonomy. Okay. I think the main thing is to be aware of that and remind ourselves of that, and think about all the ways in which that's happening, and then try to have empathy for the person who's in that position, so that you can go to a family member and say, "I'm really sorry that you had to wait 4 hours in pre-op for surgery, and I realize there's nothing you can do about it, and you are hungry." To just make those obvious statements as an acknowledgement that you're in this structure, I'm in the structure, we're all operating with these restrictions and these limitations. I think patient and family-centered care has done a lot to help people feel more autonomous, but I think we just have to remember and acknowledge that it's still diminished. So it becomes an acknowledging, remembering, recognizing, and having that factor into your communication, and to know, to accept that is true.
People online, if you have comments, we're getting to them right now. Type them in that chat box.
So we do have a couple questions already. The first one, I think I know who wrote this, and I think I know what they're getting at. So I'm going to take a little bit of liberty with the question and frame it as this. So in the authorial...
Are you taking away their autonomy?
Maybe a little bit, but I think if I am, they can always type it in again and say, "No, that's not what I meant." But I think the question concerns the authorial process of writing a memoir like this, where you make yourself vulnerable to the public. You're being very honest in many ways, very candid in many ways, in ways that some people would not be comfortable with. And yet there's still a little bit of a worry that maybe you're keeping some things close to yourself, not sharing necessarily all of it. And so the question concerns how candid you think you can be doing this, because there are social norms and expectations about motherhood and about these sorts of things that may impinge on your liberty
restrict me.
And so they're kind of wondering, are there aspects of the experience that you keep close to your heart, and how have you protected that over the years? Have you been asked about this, and
that's a good question.
whether you're being
So
fully honest about yourself or about the people that you interacted with and how you really felt about them.
Okay, well, that's a different question. First and foremost, the impetus for this book was when this happened to me, I looked for a book on the shelf that described my experience, and there was none. There was none. And so I felt ashamed, and I felt embarrassed, and I felt ugly as a person for having these feelings. So I was determined when I went to write this book that I was going to write the book for me, which was the book that included all these versions of myself that I will say I'm not proud of, but they are true. So that being said, anyone who writes tells a version of the story, and you're not going to include everything. And as far as the question of is there ways in which I wasn't candid, I would say that there are things that I wasn't completely candid about in terms of the events that happened and the providers in certain situations. I could have made them worse, and didn't, because I knew people would recognize themselves, and I didn't want to do that. And I also wanted to be compassionate about the reasons people said the things that they said, and give other people the benefit of the doubt. So there's always a certain amount of craft, obviously, that goes into telling any story, but I stand by the honesty of the book, and I stand by the stories that I tell. The one thing I would say I left out, and I heard about this, was writing about my husband and my marriage, and maybe a little bit about my daughter, but that was really because they have their versions of the story. And so initially I heard from my editor, there's not enough of your relationship in here. So I did put more of my relationship in there, but my husband's a very private person, and I didn't feel like it was my right to tell his story. So I would say I think it's an honest book, but it's also literature, and it's not a diary. Although there are some diary entries in there, but it's mostly not a diary. Yeah.
Thanks. I think that does get to what the person was asking, again, if I'm right in knowing who this was. Do you also find yourself encouraging and supporting your patients to use their voice or exercise autonomy when there's a conflict with the staff or within the staff?
Yes, I do. Yes, I do. I was working with a very difficult anesthesiologist one day, and we were bringing the patient into the room, and he had already had one sort of hissy fit after another at the bedside in pre-op. And as I was wheeling the patient in, she said to me, "I'm afraid of him." And I said, "I will take care of you. I'm here to look out for you. And if you're afraid of him, he doesn't have to be your anesthesiologist." That's not an easy thing to do. And I'm afraid of him too. And I didn't really want him to hear about it, but yes, I do. I try to I encourage them that they have a voice, even with the restrictions. I do.
I mean, it raises some issues of intra-professional autonomy.
Yes, it does. Yes, it does.
And nurses' role in particular.
Yes.
Both in a situation like that in the OR, where, I mean, a nurse who says, we're canceling the case because she doesn't want you to be her anesthesiologist.
Well, we weren't going to cancel, but I could have been in big trouble, yeah.
Or in the NICU, where the issue often, or the PICU, where the issue often comes up, how candid should the nurses be to parents about their opinions if the doctors aren't being similarly candid?
Yes, it's very difficult.
Did you have some conversations with nurses like that?
When I was working in the ICU, my first job out of nursing school was in an ICU, a small community ICU at night, and I was put in that position often. I was often put in the position of knowing more than the patients knew, and of being the person that the patients were asking for information about what was going on, and asking about prognosis. And I felt really compromised by that. I did, and it's one of the reasons why I left critical care, because I couldn't really, because of my own experience, I had a very hard time detaching in that situation, and I felt like I wasn't actually doing my job well because I couldn't detach, if that makes sense. And then I was also labeled as the one, they know you, they like you, you go talk to them about the DNR. So I also became known as the queen of the DNR because I was able to talk people into DNRs. But I didn't.
Or help them understand.
Or help them understand.
Yeah,
Yeah, that's a bad way to phrase it. Sorry. It's just true. It's the truth. It's what would happen. But yeah, help them understand. Help them through the process. As the person who understood and was able to communicate. But it's a compromising situation to be in, and I don't have an answer for it. I don't know what the solution is. It's very difficult.
Yeah.
It's very difficult because there is a level of professionalism that you need to maintain, and you have a role.
Right.
And you are not supposed to discuss diagnosis as a nurse, and you're not supposed to discuss prognosis as a nurse. That is not your role.
And there are other hierarchical systems, residents, fellows.
Absolutely. Absolutely. Yeah.
So, yeah.
Your presence.
Thank you. Thank you so much. As a NICU nurse at the clinical bedside for over 10 years, I think we all need to hear your story. And so thanks for being so brave to write it. I have a couple questions. Since you wrote the book, has anybody come back, any of the neonatologists or the people you worked with and said, I might have gotten that wrong? Has anybody come back to you?
I'm trying to think. There are individual people that I remain close to who, let me say this, I feel very supported in my version of the story by individual people that I met during that time that I am still close to. And I haven't had any neonatologists come to me and say, you know what, I could have gotten that wrong, or maybe we were wrong. But, you know, I have that moment in the book where I have a friend who says to me, if every single one of them came to you and said you were right and we were wrong, how would that make you feel any better? And my answer is no. Yeah. So I learned, I think, that that's not what's going to, that wasn't what would make me feel better, you know. And I've learned, as I mentioned, you know, that I've learned to include myself in that statement. And that's the most important thing I've learned and the most humbling thing I've learned, you know. And the thing I do bring with me to work every day is this idea that I have my version, you know, and it's a good one, but I may not be right, you know. Yeah, that's what I've learned.
You have another one?
Second question, I'm just curious to know, because I've been thinking about this a long time. It always seems like it starts with adults and it finally works its way down to babies with pain and then control. And I'm wondering, just from your perception, would a private room, having room for the family there, would that I'm just curious to know in your own experience.
I feel like it would have for me, but John and I started this conversation last night actually with, you know, what's the trade-off? Because if you have a private room, then you lose a sense of community and you see other people going through that same experience. My dearest friend from this time that I write about her in the book, my friend Holly, I would never have met Holly if I had had a private room. So I don't think the answers are simple. I do think all the things we do to promote dignity and to give people a sense of power and control in the environment, those all help. Those all make a difference. Those things would have made a difference for me. When I saw the unit upstairs, I would have been so much less stressed had I been here compared to where I was, which is not to fault where I was. It's just to say the things we're doing are helping. They're making a difference.
We have time for one more. We have another one online? Or?
Yes, we do. Going back to the discussion about the different cultural norms between, say, clinicians and hospitals and parents, and the reference to different languages and different expectations, someone's just asking if you have thoughts on how to bridge that cultural divide. If either on the parent end or your clinician end or both, if you've thought about particular strategies or.
I think the parent support groups are really helpful, and having someone on staff who has the experience in the NICU is very helpful, because that person can almost be a translator of the experience. So when that parent support person said, they say it's your baby, but until you go home it's not your baby, that was like huge for me to hear someone say that. So in terms of the language and the culture, we had at the hospital where Evan and Ellie were born, there was a book that they gave people that explained every procedure, and I actually think those things are really helpful. Having the language simplified, and because I'm not a medical professional, I don't know what you're talking about when you use initials and hieroglyphs. I don't get it. I think giving parents access to the chart and talking through the chart is really helpful. And I know there are issues that come up with that. I don't know if you guys do that at this hospital, but I don't know. I feel like if you can't show a parent what's in the chart, then I'm not sure why it's in the chart. But that's just my little innocent, naive statement.
Hey, you're an OR nurse. You are not innocent and naive. We know that.
When I document, I never document something that I wouldn't be comfortable with someone reading. I don't.
Yeah.
If I can't find a way to say it in a way that makes sense, that is respectful, then I have to find another way to say it, is how I feel.
We are at the top of the hour, so we need to wrap this up. Thank you so much for coming all the way to Kansas City from California. It's been a great pleasure to have you here. We have 2 months between this one and our next webinar at the beginning of December. In the meantime, if anybody's watching from India, the Children's Mercy Bioethics Center is going on the road the first week in November. We will be in Belgaum, Bangalore, and Bhopal the first week in November. So if anybody's in that neighborhood, come see us at those universities. And then the first week in December, Ray DeVries will be talking about medical sociology. See you then.